are starting our today's presentation on art of history taking, specifically in clinical consultation. Bismillahirrahmanirrahim. And this class is a really high yield class, and today I will teach you exactly how to take a complete history taking in a neuroclinical consultation. I can assure you that this class will inshallah be going to be very high yield and really important not only for MRCP UK PCS exam candidates, but also this class is really beneficial for MRCPI people, FCPS people, and Arab boards and our candidates from India. So, Dr. Husni, I am sharing my screen for you people. So, if
All
my
right,
screen is quite clear, please do let me know.
all right.
Is it clear?
Till now it is black. Yeah, now it is clear. The history are taking clinical consultation station. Yes.
Okay, good. Bismillahirrahmanirrahim. Today I have decided a different topic, and this topic was really much wanted. I was thinking from months to prepare the class on this topic, although I am having two previous classes on history taking, but I was feeling the need that we should update it now because now we are heading, and rather we are in pieces 23. This class I have, chosen and made this lecture very carefully to benefit every person who is a candidate for internal medicine exam. So this class, inshallah, will be first of all really beneficial because it is targeting MRCP UK and MRCPI people, and specifically the clinical consultation scenarios. But yes, if you are appearing in your any local exam of your country, so it will be really beneficial. I have spent a lot of time to prepare this lecture and consulted many books, and of course I have incorporated my teaching experience of our one-to-one sessions, premium programs, routine monthly courses, the pitfall of the history taking by the candidates, and I am coming rather in front of you with all these suggestions. History taking is the art. It is really sometimes difficult to dig out exactly what you want to listen from the patient. You want to listen something else, and patient is telling you something else. And the main challenge in your clinical life is that if you are in the exam, the time is really restricted. Now, if you are in even in clinical scenarios like in your OPDs, in your ICU setting, in your indoors, even there, if you are with me, you will, agree with me that the time is really limited because you have to attend multiple patients. So we should learn a art and we should learn a methodology how to dig out the history. Number one. Number two, my wish is that a candidate should be able to put forth or rather bring up at least three differentials based on just history. So the aim is that you should be very comfortable with the list of differentials based on the history taking. Yes, we do have the examination portion, but it is, sometime you are missing the finding, sometime you are unable to elicit the finding. So let's decide that we should make our history taking such a strong history taking and such a strong skill that we should bring up at least three differential and one should be diagnosis just based on our history. Yes, challenges are there. The main challenge is the time. So, how to dig it out? What should be the time frame? How to proceed? And specifically, how to complete it in the limited time, this is a big challenge. If you are talking, or if you are more concerned on MRCP UK PC's examination, now the clinical consultation is of almost 15 minutes. And I have already delivered a detailed lecture, rather, I will say that this is a much, much detailed lecture on how to approach this station. And this lecture is quite a lengthy one. And there I was telling you the time distribution, the way to pass this station. But now, let's summarize this, that in these 15 minutes, the task will be to take the medical history, do the relevant examination, address the patient concerns, and of course, explain the treatment plan or management plan to the patient. So you have total four tasks, I will say. Number one, history taking. Number two, examination. And number three, managing patient concerns. And number four, of course, is explain the management or treatment plan to the patient. So how to distribute the time, how to be a candidate that we should be very comfortable in completing our scenario in these 15 minutes. So I will suggest to the candidates that you should be completing your history, your medical history, in maximum 9 minutes, 8 to 9 minutes, or maximum 9 minutes. You should not go beyond that red line. You should stop your history taking in 9 minutes. And then, of course, you will be left almost 4 minutes to complete your examination, which should be very targeted one, and then 2 minutes to manage the patient concerns and explain the treatment or management plan to him or her. Dr. Hosni, everything is going smooth?
Yes, doctor. Thank you.
Okay, welcome.
Very clear.
Now, yes, now the 9 minutes, 9 minutes are not enough, and we should plan wisely, like what we should ask and what we should skip. Because this is a common complaint, rather, I will not say a complaint, a common concerns by all of my students in my courses, in one-to-one sessions, courses. That, sir, the time management is really a big issue for me. This is not just a big issue for you, rather, this is a big issue for each and every candidate. So we should be wise enough to know exactly what to ask and what to skip, and we must not skip anything important which should push us away from our logical list of differentials. So almost 9 minutes for history taking. Second important thing before we are starting this session, I want to tell you that my suggestion is that you should complete your history taking, thoroughly complete your history taking in 9 minutes, till even the systemic inquiry in how to do that I am teaching you today. Then start your examination, because if you are skipping your history in the middle, say for example you are skipping it in before the family history or before the drug history, sometimes the scenario is not straightforward and the candidate is struggling with the time, then he is skipping the history, say for example till family history, or skipping the social history, then going towards the examination, struggling with the examination, coming back, the time is really so short to complete the history. And if you are skipping the important aspect of history, of course you will lose marks. Yes, RCP has no problem. You want to start from examination, they have no problem. You want to start from history, they have no problem. You want to do side by side, no problem. But practically speaking, this is sometimes really difficult to run both things together. If you are thinking that I can take the social history while examining the patient, that's a good thing. You are allowed, but you should be highly practiced. So what I am teaching in the courses, the monthly courses, the one-to-one sessions, that try to complete your history in 9 minutes, then start your examination. Yes, in between, say for example, you are thinking that I am skipping some important question, so you can ask at that time. So it will be, more relevant and more easy and more safe approach to compile your scenario. So in the last 2 minutes, you will be addressing the patient concerns as well as explaining management plan to him. So today, this session will focus on a history taking portion. We will be focusing on how to take a good history, and the aim, or you can say the agenda, is that the candidate should be able to bring up at least three differential. One should be diagnosis just based on the history. So if you're appearing in any exam, MRCP, MRCP, UK, FCPS, any exam, you should be such a strong history taker that you should be very confident that this is my diagnosis and I am doing my examination to confirm or refute my top diagnosis. So how to do that? What are the steps? What are the precautions? And specifically, what are the common mistakes made by candidates in our courses? I will be highlighting it today. Dr. Husni, everything is fine?
Yes, yes, doctor. Thank you very much.
I have to ask because sometimes the connection can go totally, it
Yes.
can go low, so it is important to
His connection welfare. Yes, good.
yeah. Now, let's start the methodology of history taking. So, first of all, we are entering an examination hall. They will provide you some scenario, some presenting complaint, or say, for example, they'll be written some, maybe they are giving you some important examination point or vital to the patient previous workup. So, you are reading this scenario very carefully when you are sitting outside. When you are reading this scenario, you should open your mind. You should focus on few important things. Number one, what is the patient name? What is the patient age? What are the positive finding in the scenario which they are giving me, so that I should at least make my mind exactly in which direction this case may land up. So after this, I am entering in the room. I should be very confident, not overconfident. I should greet my examiner first of all, and then I am heading towards my patient, and I am starting from the greeting. Greet appropriately, then introduce yourself and confirm the patient identity. So you should be confirming the patient identity by two means. Number one is the patient name, and the other is patient age. Fourth one is take the consent, of course, for the history taking as well as examination in the appropriate way. So I am sharing with you a scheme, a general scheme. You can alter it in your own words, but I have just made it for you if you want to follow it. Hello, sir. Hello, madam. Good morning or good evening, depending upon the time in which you are appearing in the paces. My name is Dr. SM. Are you Mr. X, 56 years old, patient? Okay, little pause so that he should confirm. I am over here to take your medical history and to do your clinical examination if this is okay with you. So he should say you yes. During this process, I will be making few notes and they will remain strictly confidential with me, and my complete attention will be towards you. So you are using these words and you are starting your scenario in this fashion. First of all, there will be a presenting complaint. Any presenting complaint, racing and pacing of heart, headache, say for example, abdominal pain, say for example, loose motion, fitting episode, or dizziness, any complaint. So you are first localizing the symptom. It is very important, and this is a common mistake in our courses. Localization. I give you example. Please listen to me very carefully because this is not a typical lecture which I am delivering. I am also telling you the mistakes of the candidates, and I want you to rectify those mistakes if you're making these mistakes. So the common mistake is, say, for example, the blurring of the vision, and the candidate is starting immediately. So first thing is localization. Number one, what is meant by blurring of the vision in the patient's mind? Number two, exactly in which eye? Do not assume that this is in the both eyes. It can be in the one eye. Even if it is in the one eye, please try to localize it whether the whole field of vision is compromised or a part of it is compromised. It's very important. Say, for example, I give you example, the patient presenting to you with leg pain or lower limb pain. You are starting and you are assuming that it is the right leg. Okay, no problem. It is very easy scenario. I know I have localized. No, no, no. You will start like that. Hello, sir. So exactly where is the pain? The pain is in my right lower limb. The right lower limb is really a big organ. So I will be asking categorically exactly which part of your limb is involved, which part of the limb is having pain. Say, for example, in myalgia paresthetica, your patient will be saying to you that I am having pain in the upper and lateral part of my thigh. Say, for example, in DVT, he will be saying to you that I am having pain in the calf region. It is very important. So localization is very important. You should localize the symptom first, exactly where they are. You should be very confident that I am dealing with that area. Localization also means some other questions. Say, for example, a patient is saying to me that I am having upper thigh pain. So I have localized that the pain is in the upper thigh region. So ask two or three more questions to localize it more. Any swelling there, any redness there, any trauma there, finish. I'm not going in detail right now. Second is I am evaluating the symptoms in more detail either by OD para or by Socrates. So I should follow that pattern after localization depending upon whether the symptom is a pain symptom or a symptom is non-pain symptom. Just a second, Dr. Hussain. Dr. Hussain, are you with
Yes,
me?
yes. Yes, yes, doctor. Yes.
Okay, my screen is clear.
Yes, yes, thank you. Now, voice and images.
Okay. So I am choosing either Socrates or either Odipara. If the patient is having pain symptom, I will be heading towards a Socrate. And if this is non-pain symptom, I will be choosing Odipara. Don't bother, I'm explaining you in next couple of slides. Now, what is Socrate? And I'm explaining to you each and everything because if I believe that the candidate is taking a good Socrate, I personally believe that the pain will be evaluated completely. You can easily give the differentials of your pain. So if the presenting complaint is pain, so we are starting from Socrates. S for site, exact site. Leg is a large organ, exact site. Where is the pain? Second is onset. It started gradually or suddenly. Say, for example, a pain of disc slippage will be starting suddenly. Rather, I think I should give you the example of headache. Headache is a very common presenting complaint in our patient's exam. So, say, for example, you're getting a scenario of headache. So, we are starting from the site either in the whole head or, say, for example, in the one side of the head. So, I am evaluating it. Then onset, it started suddenly or it was gradual. Sudden means that the pain is developing over seconds to minutes. And gradual mean that you are, say, for example, studying for the paces gradually, the pain is developing, and now it is quite severe headache. So it is very important. Third is the character. Character, either it is dull, boring, or sharp, or say, for example, stabbing, but sometimes it is very difficult for you to ask, and the patient is not responding you the way he should respond. So the good question will be, sir, how it feels like, how it feels to you. This is a very good question. So he will tell you that I feel like something is stabbing or something is cramping or something is like this is a dull pain. If he's still not telling you, so you can give the options stabbing, sharp, pricking, dull, boring, something like that. Now, up till now, we have discussed site, onset, character. So just imagine how beautiful the Socrates is. If the patient is saying to me that I am having right-sided pain, only right-sided pain, so what is coming in my mind? I will be thinking about giant cell arteritis. I will be thinking about uh, acute congestive glaucoma attack. I will be thinking about cluster headache. I will be thinking about migraine. Say, for example, patient is saying to me that I am having pain in the whole head. So I will be thinking about tension headache. I will be thinking about raised ICP because of any reason. I will be thinking about medication overuse headache. Multiple things are coming. Say, for example, patient is saying to me that I am having pain in the back of my head. So I will be thinking about subarachnoid hemorrhage. I will be thinking more towards meningitis or meningoencephalitis. So these questions are making my path. These questions are strength to me. If examiner is cross-questioning to me, I can answer them. That's because of these reasons I am putting forth this differential on the top. Onset, of course, the migraine or the cluster headache will be very sudden. You are reading something, you're having attack of migraine. Tension headache or medication overuse headache, the headache will be quite gradual in onset. Acute congestive glaucoma attack will be very sudden in onset. So these things are helping me. The character. If the patient is having dull, boring pain, this is not giant cell arteritis. If the patient is having very sharp pain, this is not tension headache. Say, for example, the patient is having throbbing pain, something is throbbing in the head. It is likely migraine. This is not a pain of medication overuse headache. So these things are helping me to be very sure that in which direction my case is going. After the character, I am asking about radiation. Such a beautiful thing it is. Say, for example, the pain is radiating towards the back side, the neck side. What is coming in your mind? In my mind, meningoencephalitis is coming. In my mind, subarachnoid hemorrhage is coming. Say, for example, the right-sided pain is radiating towards the jaw. What is coming in your mind? It can be joint cell arteritis. So radiation, we are always asking in which direction this pain is going. First, is it going to any side? If he's saying yes, then in which direction? Ultimately, I am asking about associated symptoms. So just skip it for a couple of seconds and I will be coming towards associated symptoms in the end of this slide. Then the timing, any specific timing of headache. Now the tension headache can have no timings. Similarly, the medication overuse headache will be having no timings. Migraine will be having no timings. But on the other hand, say for example, you are having tumor in the brain, raised ICP, the headache will be more worse in the morning. Say, for example, the person is having OSA, obstructive sleep apnea syndrome, the headache will be more marked in the morning. So, such a beautiful question, such a beautiful narration is that the timing is also pointing towards my diagnosis. So, I'm basically collecting the evidence as much as I can. Then exacerbating and a relieving factor. Imagine the pain of giant cell arteritis will never go by any means, even if you're taking some painkillers at the home or you're having some paracetamol. On the other hand, migraine pain is also very resistant. But the patient, for example, is having tension headache, or say, for example, the patient is having dull, boring headache. When etiology, the pain will be settling for some time at least with the paracetamol. It is also a heading towards my diagnosis that exactly what are the factors which are exacerbating or relieving it. Coughing, sneezing, bending forward. These features are going towards raised ICP of any etiology. Similarly, if the headache is getting exacerbated by the eye work, like you are doing some eye work, you are reading something, writing something, it can be asthenia. Similarly, if the pain is getting improved by paracetamol, I will be thinking more towards the tension headache or something like that. But if the pain is not improving by any mean, what is coming in my mind? At least what things are coming right now in my mind? It can be subarachnoid hemorrhage. It can be migraine. It can be cluster headache. It can be joint cell arteritis. Last is severity. Now, the severity is also very important. Say, for example, if the patient is saying to you that I am having pain 9 out of 10 or 10 out of 10, the severity, how you're asking, 0 being no pain and 10 being most severe pain of your life, so how you will grade it? So say, for example, he's saying to you that I am having pain 9 or 10 out of 10. So what is coming in my mind? I will be thinking of subarachnoid hemorrhage. I will be thinking about giant cell arteritis. I will be thinking about cluster headache. I will be thinking about acute congestive glaucoma. But say, for example, this pain is 5 or 6, and my candidate is putting it as subarachnoid hemorrhage, a big blunder. Patient is having pain of just 6 or 7, and he's saying this is giant cell arteritis. So this is something which will never be forgivable. So 5 or 6 pain can be tension headache, 5 or 6 pain can be medication overuse headache, asthenia, but it will never be subarachnoid hemorrhage. Similarly, the pain on the right side of the head will never be subarachnoid hemorrhage. It will be more going towards like cluster headache, joint cell arthritis, like migraine, acute congestive glaucoma. So Socrate is helping me, and I am not deciding on one point. I'm not deciding on any one point from all these things. I am asking myself exactly what is the summary, which summary is becoming more prominent in my mind regarding the headache or regarding my presenting complaint of the pain. Dr. Hosni, everything is going smooth?
Yes, yes, thank you, doctor.
Good. Now, the last thing which is very important is associated symptoms. I'm keeping it in the last. Why? Because this is really something which need your attention in the exam. It is something which is not written in the books like that. It is testing your knowledge about each symptom, and right now we are focused more on the pain symptom. So headache, with which thing headache will be more associated? Ask yourself. Come out of the books. Just ask, just use a common sense that the patient is having headache. What I should ask? I will be asking about vertigo, accepted. I will be asking about vomiting, accepted. I will be asking about blurring of the vision, accepted. So I'm giving you examples. Vomiting, blurring of the vision, what it is, showing me. It can be the case of raised ICP secondary to SOL brain. It can be the case of meningoencephalitis. What else a headache can be associated? It can be associated with photophobia. Similarly, the patient is having pain in the epigastric region. Let's take this example. Get out of the books. Close the books. Open your mind. What it can be, what can be associated with epigastric pain? I will be bothered about, say, for example, vomiting. I will be bothered about, say, for example, jaundice. I will be more bothered about epigastric pain. It can be of cardiac origin. I will be asking about sweating. I will be asking about nausea. I will be asking about sweatings with this pain. Okay. Similarly, the patient is having a lower abdominal pain. Okay, so what is coming in my mind? It can be something linked with the gut or bowel. So I will be asking about altered bowel habits. I will be asking about a bleeding there. I will be asking about a tenesmus there. Similarly, if the pain is associated with, I gave you example of myalgia paresthetica. So it is upper thigh pain. It can be diabetic ametropy also in the differential, which is usually bilateral. So what is coming in my mind? I will be asking about numbness there, tinglings there. And also if the patient is having upper thigh pain, and you will be agreeing with me that it can be linked with some nerve compression. So with this pain, this is a common sense that I am asking about numbness, tinglings, burning sensation. So associated symptom with the pain, they are very important, and no book will teach you. The best thing is that imagine, even if you are in the exam, imagine that this patient is having pain in the epigastric region. What I should ask? This patient is having a headache. What I should ask in the associated symptoms? I hope this is clear now. Now, last thing is also the presentation of the pain. Say, for example, the patient is having pain, which is recurrent. Do you think that this is joint cell arthritis? Patient is having pain first time in the life, very severe for the last 12 hours. Do you think that this is tension headache? So these things are very important. Say, for example, patient is having first time pain in the life and very severe pain. Forget about the site for some seconds. What is coming in my mind? It can be subarachnoid hemorrhage. It can be joint cell arthritis. It can be first presentation of cluster headache. Patient is having a recurrent pain. Just forget about the site of the pain for a few seconds. What is coming in my mind if it is recurrent pain? Tension headache, asthenia because of decreased vision or blurring of the vision, eye straining, recurrent pain, it can be migraine, recurrent pain, it can be cluster headache. But if I am saying this is a recurrent pain and I am saying this is subarachnoid hemorrhage or this is joint cell arteritis, this will be a big blunder. So these questions are clarifying your path, and I am bringing up the differential in my mind after completing this Socrates completely. I'm not deciding on just one point that the site is this is this pain. No. Socrates, for any pain anywhere in the body, you must do it. And if you're skipping, take my words, if you're skipping even a single word in the Socrates, it will create a problem in the end, and you will be struggling with your differential list. Going ahead now, it is OD para. What is OD para? If the patient is having symptom, any symptom other than pain, candidate should do OD para. What is OD para and how to do it? Say, for example, I give you the example of shortness of breath or difficulty breathing. Onset, how it started, suddenly or gradually. If the patient is saying that my shortness of breath started very suddenly, I was reading a newspaper, it suddenly started, what it can be. Imagine. I'm again saying that if you're coming out of the books and opening your mind, you will easily make the differentials because the history taking is an art. You cannot learn it from the books. It is all about your mind and how you are correlating the things and how you are digging out the symptoms. Patient is having sudden onset of breath. What is coming in my mind? Forget about other symptoms. Just I am coming in your room. I'm saying, Dr. Husni, Dr. X, I'm having severe shortness of breath. Suddenly it started. What is coming in your mind? It can be pulmonary embolism. It can be pneumothorax. It can be panic disorder. Yes. But if it is chronic pain, chronic shortness of breath, it is happening for about 6 months, 1 year. Will you keep pneumothorax in your differentials? Will you keep DVT or pulmonary embolism differential? Big no. And the candidates are making these mistakes out of confusion. I'm not saying that they don't know, they know very well. But because of confusion, they are picking up wrong differentials. So the pain, the shortness of breath is quite of the chronic duration. So COPD is coming in my mind. ILD is coming in my mind. Asthma attacks, repeated attacks, even the asthma will be in repeated attacks is coming in my mind. So the differential will change. Then D duration. Since how long I am having the shortness of breath? It is happening just for 3 to 4 hours. Pulmonary embolism, pneumothorax, panic disorder. It is having for the last 6 months. So things are, again, I have explained that things will be quite different now. Similarly, progression. Is it getting bad? It is getting progressive or it is same. So if you are thinking, just imagine the patient is having SOB for the last 6 months duration and now it is getting progressive. How I will know? Initially, my patient was able to walk for about 100 meters and now he is walking just for, you can say, 10 meters. So what is coming in my mind? It can be a more, you can say, the progression of COPD. It can be, say, for example, ILD with a progression. It can be, say, for example, some pathology which is now getting worsen out. So it is important to even ask the progression of the symptom, any symptom which you are suffering, even if you are evaluating diarrhea, loose motions. Then aggravating factor. What is aggravating your symptoms? Say, for example, right now we are focusing on SOB or shortness of breath. What is aggravating it? Whenever I am listening a bad news or some news about my career or studies, I am having SOB. So it can be panic disorder. Whenever I am going to my work in the workplace, my SOB is getting bad. Occupational asthma. It is very important to categorically ask these questions to the patient. It will not charge your maximum 3 or 4 or 5 seconds, 10 seconds. Candidates are doing this mistake. Sir, what aggravates your SOB? He's saying nothing. Please categorically ask. Say, for example, you're asking about what is aggravating your loose motions. Nothing is aggravating my loose motions. No, it is very good to ask about any milk product, say, for example. Say, for example, any wheat or wheat products. Okay. Say, for example, stressor to stress days. So it is very important. So, aggravating factor. Say, for example, you're dealing with pedal edema or foot swelling. So, what is accelerating it? Nothing is accelerating it. So, you are thinking that this is likely a case of CKD or likely a case of heart failure. But in the end, what we are getting that it was getting accelerated when he was standing for a long time. He's a policeman. He is not having any CKD or CLD or say for example heart failure symptoms. So you should ask categorically exacerbating or aggravating factor, then relieving factor. What is improving it? You are saying this is intermittent, coming and going. What is improving it? Away from work is improving it. Any specific diet is improving your diarrhea. Any medication is improving your diarrhea. Any postural change improving your SOB. What is improving it? So it will give you the clue. Then associated symptoms, again they are very important when you are evaluating any symptom other than pain also. I give you example. Say for example, let's discuss SOB. What can be associated with SOB? Imagine I am having SOB for 6 months. What can be associated with SOB? Cough, yes. Film production, yes. Wheeze, yes. Chest pain, yes. Orthopnea, PND, yes. Say, for example, you are dealing with the symptom of diarrhea, loose motion, a common symptom. What can be associated with that? Bleeding PR, yes. Abdominal pain, yes. Vomiting, yes. Uh, Upper abdominal discomfort after food intake, yes. So I am using my mind that what can be associated with this symptom, because I want to make my mind, because diarrhea, because say for example SOB, these symptoms are very broad. So I need to rule out the associated symptoms, the cut short the things to be on the right track. So associated symptoms should be sought out very carefully. And take my words, I'm always saying that PACES is all about smart work. It is not about hard work that you are opening up the books and you're doing rectification and crammings. Nothing will happen. You have less time, you have short time, you have limited amount of memory. You can, compile or store the things limitedly in your mind. Why? Because ultimately, if you are gaining extra, you will get saturated. You will omit important information from your brain, and less important things will stick there. So ask yourself, make your habit when you're taking the history, when you're attending the courses, ask yourself what can be associated with this symptom. So now let's go ahead. After completing two things, first was a localization of the symptom. Then, of course, I have done either OD para for any symptom other than pain or Socrates for the pain. I am heading toward the specific history of presenting complaint. Now, this is slightly discussion which will be slightly at the it is slightly complex, and we should be focusing over there, and each and every symptom is having its own specific history. Dr. Hosni, my voice is clear and loud.
Yes, doctor, thank you. Clear.
Okay, so I will be taking your at least 10 minutes or 5 to 10 minutes in this slide. So please pay attention, because I am uttering some important question of each symptom, and you should absorb them. You should write them. You should make your notes. These questions are really high yield to clarify your differentials. Say, for example, patient is coming with blurring of the vision. You have localized it. You have done your OD para. Now, it had specific history. What is the history? Let's start from anterior chamber. Problem is in the anterior chamber. What can be associated with the blurring of the vision? Number one, watering from the eyes. It is showing me some allergy, some conjunctivitis, some uveitis. Then redness or pain in the eyes. It is showing me something called conjunctivitis, uveitis. Then discharge from the eyes. Then, of course, it can be photophobia. Photophobia means either my cornea is getting involved or I am having some link with my diagnosis towards meningitis. So, what I am asking with the blurring of the vision in anterior chamber, I am asking about watering, I am asking about pain in the eyes, I am asking about redness in the eyes, I am asking about photophobia. Even the pain is showing me that this patient is having either conjunctivitis, uveitis, keratitis. Then I am going slightly behind. And what is there? There is crystalline lens. If there is, say, for example, cataract, you will get a flare or glare of light. So you're asking, any glare or flare of light with this blurring of the vision? Yes, I'm having. You usually at night, it can be cataract. Then you are going behind the lens. What is there? There is your friend retina, optic disc. So we are asking some specific questions of this location also. So optic disc lesion usually presents with scotomas, any black spots or black clouds in front of your eyes. Even some retinal pathologies do present with scotomas. So are you able to see my whole face clearly, or there are some black spots or black clouds there? Then optic disc problem can present with, very commonly in multiple sclerosis, with optic atrophy. It will be again this, you know,
Okay.
uh, lesion of Dr. Hosni. There is some problem in your mic, please. Some noise there. So
Yes,
it will
yes,
again
but
present with,
solve it, doctor. Yes, thank you.
okay, it can be black spots or clouds. Optic disc problem in multiple sclerosis can present with optic neuritis, common presentation multiple sclerosis. So you are asking with this blurring of the vision, the symptoms of optic neuritis. Usually two symptoms. Number one, color desaturation. Color desaturation is not something called color blindness. It is like a red color is very bright in one eye and it is less bright or dull in the other eye. This is called color desaturation. Then the second question, optic neuritis, will be uh, pain on the eyeball movement. As the patient is moving eyeballs, he is having pain there. It is also showing us that the patient is having optic neuritis. So we are still taking the history of the blurring of the vision. What else? I am now asking about any double vision. Why the patient is having double vision? Double vision is happening that the one eye is looking in one direction and the other eye is looking in other direction. It is happening because of loss of eyeball or decrease in eyeball movement. And when it is happening in two conditions. Like if the muscle, extraocular muscle is involved, or if the nerve supplying that muscle is involved. So you will get double vision. Then I will be even asking in the blurring of the vision about bumping into objects. What it means that the patient is having lesion in the optic chiasma and it is compressing. Sorry, the lesion is in the pituitary gland. It is compressing an optic chiasma, and we know very well that in the optic chiasma, the nasal fibers of the retina are crossing. So the patient is having lesion or tumor in the pituitary gland. It is compressing on the optic chiasma, leading to the destruction of nasal fibers, and the nasal fibers of the retina are responsible for temporal field of vision. So patient is bumping into sideways. Patient is bumping into side objects. So I have given you example. The patient is having blurring of the vision, and under this slide of specific history, now after OD-para, you are asking these questions. How many questions? I have given you reasoning of each and every question. Redness in the eyes, pain in the eyes, watering in the eyes, photophobia, glare or flare of light, specifically at night, any black spots or clouds in front of your eyes, any pain on the eyeball movement, any color desaturation, any bumping into objects, any double vision. Now your history has been completed of the vision problem. Say, for example, another common symptom I am evaluating for you, taking for you, loose motions. Diarrhea, very common symptom in our cases. So, what are the specific questions of loose motion in the PACES after OD-para? Number one challenge will be that this is acute diarrhea or a chronic diarrhea. If this is chronic diarrhea, it is totally continuous or it is intermittent. Third challenge will be, is this a small bowel type diarrhea or a large bowel type diarrhea? Because the pathologies are totally different. Approach is totally different. Even the way you are doing scope, that is either colonoscopy or upper GI endoscopy, they are totally different entities. So what are the difference between large bowel type diarrhea, small bowel type diarrhea, and why it is important? Because the upper symptoms, I'm not teaching you gastroenterology. I am teaching you internal medicine right now. So I will be teaching you what is required at your level. So in your cases, you will be getting a symptom or a case of celiac disease, or say, for example, pancreatitis, or say, for example, giardiasis. On the other hand, the case of IBD is coming in the exam. On the other hand, acute dysentery is coming in the exam. So how I will be very sure exactly what is the diagnosis? So for that, after OD-para, the first step will be whether this is acute diarrhea, chronic diarrhea. Number two, if this is chronic diarrhea, is it continuous or recurrent? Say, for example, a patient with having celiac disease will be having a continuous chronic diarrhea. He is daily having roti, chapati, pizza, pasta. A patient having IBD will be having intermittent diarrhea. So there's a hell of difference. Then we have to differentiate between the large bowel type diarrhea or small bowel type diarrhea. Small bowel type diarrhea is having very large amount, high volume, because of malabsorption. Food is there. Your gut capacity to absorb that water and fluid and food is decreased. On the other hand, if you are getting a case of colitis or IBD, the diarrhea will be of small in amount. Why? Because already everything has been absorbed except some amount of fluid in the terminal ileum. Small bowel type diarrhea will be having undigested food particle consistency. Large bowel type diarrhea will be having a watery inconsistency. Small bowel type diarrhea is usually malabsorption. It is having no pain. Large bowel type diarrhea, your IBDs, your microscopic colitis, your dysenteries, your tumors, they will have pain. Steatorrhea, the stools are floating on the pans. You're asking this beautiful question. It is the symptom of small bowel type diarrhea. The patient having large bowel type diarrhea, on the other hand, they will be having sense of incomplete evacuation. They are sitting on the toilet for hours, at least not for hours, at least for the minutes, like 30 minutes, 20 minutes. They are having a sense that the stool is coming, but it is not coming. It is happening because there is inflammation in the rectum. Mucus is a symptom of large bowel type diarrhea. So these questions are very important if, say, for example, you are evaluating a case of diarrhea. Ultimately, still, if we are dealing with chronic diarrhea, we are missing multiple questions. We are not asking about whether you are getting up from sleep to pass these loose motions at the night or not. You are not asking about the IBD questions because your friend Crohn disease can present even without bleeding PR. How you will know that it's a Crohn disease? So I should ask about questions of uveitis like pain in the eyes, watering from the eyes, redness in the eyes. Ever you got any sores in the mouth, any joint pains, erythema nodosum, pyoderma gangrenosum? These questions must be asked to rule out IBD. Similarly, you are getting a case in the exam of pedal edema. It is very important to ask the related questions. So after Odipara, in this specific history, I will be focused more towards, how it is developing. It is fixed or not, pitting or not. When I am seeing a pedal edema in the patient, first thing is coming in my mind whether the patient is having any history in which he is standing for prolonged duration. I will be asking about associated pain there to rule out DVT. I will be asking about any swelling, any redness there, any pain or restriction in the joint movement to rule out your friend cellulitis, septic arthritis. After these, I am still bothered that the patient is having no inflammatory signs, only pedal edema. And moreover, this pedal edema is not unilateral to say that this is inflammatory, this is bilateral. So what is coming in my mind? Immediately, I am asking about racing and pacing of heart. Immediately, I'm asking about orthopnea PND. Immediately, I'm asking about SOB, specifically on lying flat. I am bothered about CKD. It can be linked with CKD. Any increase or decrease in amount of waterworks, any increase or decrease in frequency of your waterworks. Waterworks means the urination. Any foam in waterworks, any itching anywhere in the body. Anybody is telling you that you are getting pale than before. Any eye swelling, bilateral pedal edema. I am bothered about CLD. I will be asking about jaundice, tummy distension. Ever you got any episode of bleeding in your vomitus or in your back passage? So I am taking the history according to that symptom. Similarly, say for example, I am getting a case of cough. It has its own history. After Odipara, it is important to know exactly which sort of cough is that. Is it productive or not? Any specific time it is coming? Whether it is associated with SOB or not, whether it is associated with the V's or not. Even sometimes the GERD is presenting with the cough in your paces. Extra esophageal manifestation of the GERD is your cough. You are not getting anything, no SOB, nothing, no wheezing, no chest pain, no orthopnea, no PND, no pedal edema, only cough. What I should think about? I should also be thinking about other causes. Say, for example, GERD. Similarly, hematemesis. Patient is coming to me with hematemesis. It has its own history. I will be doing Odipara. After that, I am bothered about other symptoms. Amount of blood in vomitus. He is saying, I am just having a spoonful of vomitus, blood. It is difficult to digest that this is hematemesis. He is saying that I am having a cup full of blood. So it is likely because of, hematemesis. I am bothered about the color of bleeding in the vomitus. If it is very fresh blood, likely the bleeding is happening from the proximal site, oral cavity, esophagus. If it is coffee ground, likely the blood has been oxidized. It has been staying in the tummy before coming out. So I am asking about the bleeding color. Coffee ground, tummy. Fresh esophagus. Whether you are getting any melena or not. Any history of weight loss. Who knows this patient is having cancer? Ever you got any episode of vomiting before this hematemesis? It is making my pathway clear for two diseases, two conditions. If the patient is having first episode of hematemesis, right now he was reading newspaper, he is vomiting out the blood, likely the origin is GI and likely it is something chronic. Say, for example, patient is vomiting, simple vomiting, and suddenly he is vomiting out a blood, fresh blood or coffee ground, likely fresh blood. This patient is a case of Mallory Weiss of or Bohr-Heave syndrome. Bohr-Heave syndrome means that the patient is having through and through rupture of esophagus. If the patient is having just a mucosal break, this is Mallory Weiss. So even then, I will be really bothered to ask about sorry, something called bleeding from any other orifice of the body. Maybe this is a case of Osler-Weber-Indau syndrome. This is not a GI case. Patient is also having apextaxis. Patient is also coughing up the blood, hemoptysis. Patient is also having hematuria. So story is changed. So specific history of each symptom should be explored, and we are teaching it regularly in all our courses daily on the daily basis approach of each symptom. So we should learn, we should memorize each question pertinent to each symptom to be on the clear side that this patient is having, say for example, hematemesis, diarrhea, SOB, cough, chest pain because of this reason. Now, the next step is to digging out the differential diagnosis or etiology of the symptom. It is very important. Now, what I mean by digging out, I was talking about hematemesis. Let's continue with that. What are the causes? I will be thinking about this patient is having hematemesis. I'm very sure this is hematemesis. What are the causes? It can be peptic ulcer disease. So if I want to say that this bleeding is because of peptic ulcer disease, I should elaborate over there that this patient is also having previous episodes of tummy pain and vomiting.
Dr. Salman, I'm sorry, I should do my Maghreb prior. I'm really sorry, doctor. It will
You
be
want to
the
mute your
time of
mic?
Maghreb prior. Yes, yes.
Okay, okay, okay. Okay, no problem, no problem. You should say
Sorry,
your prayer,
doctor.
then get
Thank you
back
very
to
much
no
for your
issues, no
excellent.
issue. So anybody, please come forward with a no background noise because Dr. Husni is going for the prayer, so that we should run our session smoothly. Anybody with no background noise, please come forward. Use the raise hand option, and I will unmute your mic. We are getting late. Anybody listening to me, please use the raise hand option to come forward so that I can unmute the mic because my voice can go low anytime. Anybody, please. Anybody, please, with no background noise like Dr. Husni, please come forward. He has gone for the prayer. We need to continue our session, please. it will be very difficult to know that there's connection problem. So better to keep one mic unmuted. Dr. Rasin, please unmute. Hello? Dr. Rasin, my voice is clear to you people? I am not listening your feedback, Dr. Rasin. Dr. Rasin, are you people able to listen to me? Any other person with no background noise, please come forward. Because I think Dr. Rasin mic is not working. I am not listening to him. Hello, anybody please? Anybody come forward? We are getting late. Dr. Rasin, anybody? Because I will not be able to read the Zoom chat box. You people are texting me in a Zoom chat box. I will not be reading Zoom chat box when I am presenting in on the slide. So anybody with no background noise, Dr. Rajib, please unmute.
Good evening.
Yes, good evening, Dr. Rajib. My voice is
Uh,
clear.
yeah, that my differential diagnosis will be peptic ulcer disease, varicose bleeding.
We are, Dr. Rajib, we are not discussing. We are just, I am requesting you to keep the mic unmuted and let me know if my voice is getting low, okay?
Yeah.
Okay. So please keep your mic unmuted and we will be discussing the history taking, okay?
Yeah.
Okay, please keep it unmuted. Okay. So we were discussing differential diagnosis. The patient is having hematemesis. I am thinking about peptic ulcer disease. So I should elaborate that the patient was having previous history of abdominal pain, previous history of vomitings. Similarly, if I am thinking that this is because of esophageal varices, their rupture, so I will be thinking about decompensated liver disease. So I will be asking about jaundice. I will be asking about any loss of body hairs. I will be asking about any breast enlargement. I will be asking about any abdominal distension in the past. I will be asking about any altered sensorium to demonstrate that the patient had episode of hepatic encephalopathy. So this way I am making my differentials. Say for example, I am thinking that this patient is having oscillor Weber, so it can be something systemic. So I should be asking this question, any bleeding anywhere, and this patient is having, say for example, apextaxis, also hemoptysis, also hematuria. So now it will be my blunder if I am keeping CLD on the top. It will be a blunder to keep peptic ulcer on the top with this upper GI bleed. So similarly, let me give you one more example of shortness of breath. If the patient is having SOB and this is a chronic one, I should be exploring all the causes in a very short format about chronic SOB. So if the patient is telling me that this is continuous all the time, and even it is there when I am, having walking for some time, so I am thinking about ILD, I am thinking about a COPD, and the patient is saying the cough. So, if this is a productive cough with the wheezing, especially noisy breathing, so I will be thinking about COPD. If my patient is saying that I am having SOB with dry cough, so I will be exploring about ILD. Similarly, if my patient is saying to me that I am having SOB and is chronic but episodic, so I am asking the next question will be that is it with noisy breathing or not? To say that or to be confident that this is asthma. So each symptom, if you are listening to me very keenly, say for example cough, say for example SOB, say for example if this is diarrhea, any symptom, it has its own history you should take after completing OD para. After that, the next step will be to take the history of that relevant system, sorry. Say, for example, you are getting the history of SOB. For me, the SOB is falling under two systems. Either it is pulmonology or it can be cardiology. So I should explore the other symptoms of these systems also. If I have asked some, I will not repeat. Repetition is always creating a bad impression. So if you are missing something, so SOB is linked with cardiology as well as our pulmonology. So in the cardiology, I am asking about orthopnea, PNG, pedal edema, racing and pacing of heart. If this is pulmonology, I am asking about noisy breathing, cough, sputum, chest tightness. Say, for example, I am getting a symptom of loose motion. The next step should be to ask all relevant symptoms of abdomen. Ask myself if I am missing or not. If I have completed all while taking the history of loose motion, that's a good thing. If I am missing something, so under this heading, I should be asking about all symptoms of GI because the diarrhea is linked with GI. So I am asking about oral sores. I am asking about dysphagia. I am asking about abdominal pain. I am asking about tenesmus. I am asking about jaundice. I am asking about bleeding PR. So I should be covering completely that system in which my symptom is falling. But keep in mind, if you have asked some questions before, now you will not be doing any repetition. Time to move towards the general questions. And I am always saying that this is these are bullets and they are really helpful in making or refuting any differential, and you people should learn it by heart, and these questions should be asked in any case because they are unconsciously ruling out multiple differentials. I give you example. First, you are asking about increased body temperature, fever. So if the patient is not having fever, you are ruling out multiple things. Excessive sweating, no excessive sweating, so I can say that the panic disorder, say for example hyperthyroidism, say for example MI is going slightly down the list. Say for example, then the third question is weight changes, and this is a very common mistake in our patients candidates, that they are asking, do you have any weight loss? So better is that you should ask any changes in your weight, because it will also cover the increase in weight. So the weight loss, you are ruling out unconsciously cancers, unconsciously TB. And if the patient is having a weight gain, what is coming in my mind? One cancer is leading to weight gain, and that cancer is insulinoma, tumor, I will say, not cancer, tumor. Then you are gaining, or you can say you are getting confidence if the patient is having weight gain, that this patient can be a patient of OSA. If the patient is having weight gain, it can be hypothyroidism. So these questions should be learnt by heart by all the candidates to reach the diagnosis very smoothly. Then any excessive fatigue. Excessive fatigue is showing some liver compromise. Say, for example, PBC, PSC, acute hepatitis. It is also showing, say, for example, SIADH. It is also showing, say, for example, heart failure. Excessive fatigue is also showing me anemia. Excessive fatigue is also showing me Lambert-Eaton or myasthenia. The myasthenia, it is usually in the evening. So such a beautiful questions they are. By one question, I am ruling in or ruling out a multiple differentials. Then any rash, spots, or pigmentation on the skin. I am always teaching in my courses that the rash will never cover pigmentation of the skin like in Addison. Pigmentation will never cover the rash. Spots will never be covered under the rash. So it is very important to ask the three questions simultaneously to the patient. So, do you have any rash, spots, or pigmentation anywhere in your body. Should be very confident that you are safe from the skin. Then how is the diet, appetite, ultimately the sleep? And sleep is, it is ruling out multiple things, like the patient with the OSA do have disturbed sleep, the patient with orthopnea PND do have disturbed sleep. Similarly, multiple other conditions like in the backache, if the patient is having sleep problem at the night, this is itself a red flag. Then abnormal shakiness. Such a beautiful question it is, that it is ruling out at one point your friend pheochromocytoma, at the other point hyperthyroidism, at the other point hypoglycemia. It is also ruling out panic disorder. It is also ruling out Parkinsonism, Parkinson disease. Rather, this word is slightly crude to rule out. I will say it is, if the symptom is not present, it is pushing your differential down the list. Then lumps and bumps, they can be of different types. Like it is lymphadenopathy. It can be lump in the neck, like you are asking, sir, do you have any lump or any bumps anywhere in the body? So patient is bound to tell you that I am having now lymphadenopathy, or I am having, say, for example, lump in my neck. So now you are putting the ball in the court of the patient. Then ultimately, I am also asking about dizziness on standing from the sitting posture. This question is also covering multiple things. See how beautiful this question is. You are ruling out symptomatic anemia. You are ruling out orthostatic hypotension because of any reason. You are putting down the differential of Addison disease. You are thinking of Parkinson, and you are putting down the differential of Parkinson plus syndrome with ruling out dizziness. I'm not saying that it is totally, absolutely not, but I am saying that I am collecting evidence. Doctor, doctors, are you listening to me? Please, Dr. Rajib, use the raise hand option to come forward. Dr. Husni, mics are muted. I need one mic unmuted to proceed, please. Anybody with no background noise, please come forward, because one mic should be unmuted. My connection can go low anytime. I need confirmation. Dr. Rasin, are you listening to me? Dr. Samra, please unmute. Dr. Samra, my voice is clear. Dr. Samra, Dr. Rasin, Dr. Rajib, please unmute. Dr. Rasin, Dr. Samra, I am not listening from your mics. Dr. Rajib, please unmute. Dr. Sumaya, please unmute.
Yes, we
Hello?
are hearing you. Hello,
Yes,
good evening.
yes. Dr. Sumaya, please keep your mic unmuted for me.
Okay.
Okay. So let's go ahead. And I was discussing our general question. I'm saying that these questions are really important and really helpful in ruling in and ruling out multiple differentials, and you should learn them by heart. And take my words, it will not cost more than 45 seconds to ask all these questions very smoothly. After that, after evaluating your presenting complaint, after asking the general questions, now it's time to move towards the past history. In the past history, first thing you will ask, any previously diagnosed condition if you're having. So if he's saying yes, then you will be asking whether they are in well controlled form or not, and if you are in any regular follow-up or not. Say for
Follow
example,
up.
the patient is saying to you that I am having diabetes, I am having hypertension. So you are asking first question, are they in well control or not? If not in control, of course, I am thinking on multiple possibilities. Secondly, are you in a regular follow-up or not? Why? Because if the patient is in regular follow-up, I can say that the patient is likely monitored. If the patient is not in regular follow-up, patient is a cancer patient, not in regular follow-up. Patient is a diabetic or hypertensive, not in regular follow-up. So multiple possibilities are coming in my mind. Similarly, the second question will be for long-standing illnesses like diabetes, hypertension, or say, for example, I'm giving you examples, chronic liver disease, explore their complications and sequelae swiftly. So this is our scheme we are teaching in our courses that if the patient is diabetic, first thing you're asking duration. If the patient is having diabetes for the last 1 year or the patient is having diabetes for the last 25 years, it is much different. The scenario is much different. So patient is diabetic for the last 25 years. I should make it a habit, or say, for example, hypertensive for long duration. I should make this habit that I am asking and ruling out complications. Number one, start from head to toe, head to toe, head to toe. Decrease vision. He or she can have hypertensive or diabetic retinopathy. I should be asking about any episode or any history of stroke before, any chest pain ever. Then, of course, any increase or decrease in waterworks, any foam in waterworks. So I'm ruling out CKD. Then I am asking about any pain on walking, which is dedicating peripheral arterial disease. Then any numbness tingling in the hand and feet for saying that this is peripheral neuropathy. So it will take maximum 15 seconds to rule out these complications. The patient will be saying yes or no. So first thing, any previously diagnosed condition. Second thing, is it control or not control? Third thing, are you in regular follow-up or not? I give you example. Diabetic patient should be followed at least yearly with the nephrologist, with the ophthalmologist, and podontist. Then second question, sorry, fourth question is that any complication linked with my past history. And then the third question in the past history, which you are seeing on your screens, is any surgical, medical, dental procedure or tattooing done previously. So surgical procedure, say for example, a patient is having some surgery, they have removed, say for example, parathyroid gland. So it can be the case of hypocalcemia. Patient is having any medical procedure, say for example, lumbar puncture 3 days back, you are catching diagnosis. This is lumbar puncture induced headache. There's some noise in the mic. Some mic is open. There's noise. Please avoid the mics because of noise for smooth running of the session, please. I'm thankful for your cooperation. Then ultimately, next I am going toward the dental procedure. You know very well the infective endocarditis, the fevers, then of course, say for example, the patient is having dental procedure right now presenting with cavernous sinus thrombosis. So you are getting evidence. So this is a habit in the past history that we are asking, sir, have you undergone any surgical, medical, or dental procedure? Of course, tattooing. Tattooing is really important, like we are asking about IV drug abuse with needle sharing, because we are getting evidence of HIV or infective etiology of hepatitis. We are gathering evidence of infective endocarditis. Ultimately, previous hospitalization. If the patient is saying that I am having a repeated or 1 or 2 hospitalization, first question should ask why, and the second question, which treatment has been given. If he is telling you the treatment, say for example, he's saying to you that I was admitted in the hospital 15 days back, and right now he is presenting to you with a loose motion. So my question will be, number one, why you were admitted there? Pneumonia. How they have treated that pneumonia with antibiotics. Diagnosis is in my hand. My patient is having pseudomembranous colitis. So these are the clues, and we should follow this scheme. Then allergies. Allergies are very important, specifically in the skin or dermatological conditions and also in the pulmonology. So we are asking about foods, medications, vaccinations, pollens, or dusts. Let's go ahead. Now, this part of the history and this portion of the history, what I believe from my teaching experience is that the candidates are having difficulty here. And the main reason they're having difficulty is that they are not learning these questions by heart. And why these questions are important and critical and crucial, I am explaining to you in next couple of seconds. Often the diagnosis is hidden over there. Now I will explain to you each and every point. So in the medication history, first question, can you please show me your medication list? So they are usually having a medication list and he will show to you and you will read or you will confirm which medication he is taking. Number two question, since how long you are taking these medications and in which dosage? So it will tell you that, say for example, this patient is having upper GI bleed and you are saying that it is happening because I am seeing a diclofenac sodium in the list. Upper GI bleed happened 1 day back and he started taking NSAID 1 day back, so it is not making some temporal relationship and you are missing your diagnosis. Say, for example, patient is having ILD and you are making it a case of methotrexate-induced ILD. He is showing you methotrexate in his list. And you are not asking how long he is taking methotrexate and you are putting it as a complication of methotrexate. He is using methotrexate just from the 15 days. And he is having SOB for the last 6 months, or he is using methotrexate for the last 4 months and SOB started about 6 months back. So it is very important to ask exactly for how long this patient is taking this medication list and in which dosages if they have not writing the dosage. Any recent start or change in the dose of any medication, specifically before the onset of these symptoms, then this is a very common mistake. So say for example, what I mean, candidates are usually asking this question, any start of any medication recently, and the patient is saying that I started taking ACE inhibitors. Okay, and they are saying that this dizziness is because of orthostatic hypotension caused by ACE inhibitors. Question should be whether this ACE inhibitor was started before the onset of dizziness or not. Patient is having pedal edema bilateral and you are seeing amlodipine in the list and you are asking, sir, do you have any recent start of any medication? Question is technically wrong. Ask about any recent start of any medication, specifically before your these symptoms, because we need to get temporal relationship of each drug. If we are unable to make a temporal relationship, then there will be cross questioning that you are saying this medication is responsible. Are you asking since how long the patient is taking? And whether it is started before the onset of symptom or after the onset of symptom. Then the fourth question is any recent stop or stoppage of any medication, specifically before the onset of these symptoms. It can be that a disease was suppressed or symptom was suppressed because of any medication and they have stopped it before the onset of these symptoms and the patient is getting the result of it. So we are asking the recent question, the recent word, but correlate it with the symptoms. That is very important. Then fifth question is, are you compliant with them? Are you compliant with these medication? If no, then any specific reason or side effects. Patient is showing you a medication list. Patient is throwing a medication list in front of your eyes and you're very confident that the patient is taking this. But you are not asking this question, are you even compliant? Yes, they have prescribed you, but are you taking it? This question is very important, and lot of candidates do miss a diagnosis because of lacking this question. They are assuming that the patient is taking medication. In the real, the patient has been prescribed that medication, he is not taking it. Any other medication beside this list, like over the counter preparation or herbal preparation or supplement, your patient is having acute liver failure and you are not bothered about herbal preparations. Your patient is taking over the counter preparations like paracetamol and landing up in ER with acute liver failure. You are not bothered. It was not prescribed in the list. Your patient is, say, for example, taking some supplements leading to Cushing guide disease. So it is very important that you should be linking the Cushing disease with those supplements which contain steroids. So these questions are very important. Other than the list, the medication which you are taking. Dr. Sumaya, are you with me? Dr. Sumaya, please, I think your mic is muted. Please unmute.
Yes, doctor.
Yes, my voice is clear to you people?
Yes, it is doctor.
Amazing, amazing. Please continuously give me feedback because sometimes the connection is not stable, okay?
Yes.
Otherwise, you people will miss important information. Okay, let's go ahead. History taking. Now I am exploring more clues. I have taken past history, allergies, medication history, PALM, past history, allergies, medication history. Time to move towards the family history. Number one question, any evidence of similar condition or symptoms in your family? You are gathering the clues. Any other disease which runs in the family, you are exploring the genetic basis. Any sudden cardiac death or heart attack or something like that, or death linked with the heart condition in your family. Cardiac is a jargon. So you're asking, it can be a case of HOCM, early cardiac deaths in the family. It can be hypertriglyceridemia leading to premature MIs. So it is important question. Any cancer running in the family, patient is having dysphagia, patient is having upper GI bleed, patient is having SOB, patient is having fitting episode, patient is having, say, for example, any tumor, and you are getting a family history of multiple tumors. It can be Lynch syndrome, HNPCC, so multiple things can be there. So these questions are very pertinent, and these questions should be explored when you are taking the history. And if you are not taking a structural history, it is not only for you, but also likely marks will be detected. Ultimately, last but not least, if you are suspecting a communicable disease like TB, like flu, like something like that, then you should explore similar symptoms in the friends or co-workers of the patient. Patient is having, say, for example, TB. You are exploring family history, and you are not getting any history of TB, but the patient is having the TB person in, say, for example, office. So communicable disease. This point should be incorporated in your neurons, that you should be asking this question beautifully and confidently, the disease or the contact with any sick person. If you want to summarize it, you can ask any contact with the TB person, or say, for example, flu person, or say, for example, the patient who is having respiratory problems, chest problems. Now we are entering in a sensitive zone of history taking, and it is not always necessary, and we are usually exploring it if our disease or our symptom is pointing towards that etiology. So you can omit that portion, and if you are asking the questions in this domain, you should be very confident that yes, my diagnosis can be linked with this portion. Sexual history. Are you in any long-term relationship? It is very important. Then, if yes, any kids? Second question, any casual partner. any extramarital affairs? If he's saying yes, then inquire about sexual orientation, extremely sensitive question, safe sex practice, and briefly ask about STDs, gonorrhea, discharge, sores on the private area, discharge from private area, lumps and bumps near private areas. Because this is a sensitive zone, so I should be asking like that, sir, I need to ask you a few sensitive questions. I hope you will not mind, and I do ask these questions to a lot of my patients to aid in the differential diagnosis or diagnosis. Then you will explore these questions in extremely non-judgmental and polite way. Gynecological and obstetrical history, and it is linked with only to the female patients, and there are 4 P's, and you should digest these 4 P's. If there is female, digest these 4 P's. Take my words. So number 1 P is periods. How is the routine of your period? Such a, you can say, open-ended question. It is covering multiple things. Routine of periods, frequency, amount, pain, regularities, irregularities. So you're throwing a journal question. When you had them last time? Number 1. Number 2, second P, any chances of pregnancy at present? Because some conditions are linked with pregnancy. Some conditions are coming in internal medicine, you know very well about, DVTs, you know very well about acute liver failure in the pregnancy, liver condition in the pregnancies, fatty liver in the pregnancies. Then you know very well cardiac problems in pregnancy. So you should be asking about any chances of pregnancy right now. Third question, uh, uh, P for previous pregnancies. Any complications or any sequelae of the previous pregnancies. Say, for example, you are dealing with the cardiac patient, she is female, and you are missing a cardiomyopathy linked with pregnancy. You are dealing with a patient having thyroid problem, and you are missing the postpartum conditions which are affecting thyroid. So it is important to ask about any complications or anything or any conditions after the delivery. Specifically, I give you another example. The patient is having massive postpartum hemorrhage and you are missing it. You are not asking it. And right now in your room, the patient is of Sheehan syndrome. So the third P is previous pregnancies. Fourth P is pills. Are you taking any pills, OCPs? In the UK, pills mean OCP. Pills mean something linked with contraceptive. So to clarify it, say for example, you're appearing in some other center, so you can clarify it, any birth controlling medications. Dr. Sumaya, my voice is clear? Hello? I think the mic is muted. It might be from my side. Dr. Sumaya, please unmute it. Dr. Sumaya, please unmute your mic. Any candidate over there with no background noise, I am unable to contact Dr. Sumaya. Please come forward and unmute the mic. Dr. Rasin, please unmute. Hello? Dr. Sumaya, Dr. Rasin, Dr. Husni, please unmute.
Oh, okay, Doctor. Thank you. I finished my prior. Thank you, Doctor, for waiting me.
Okay, welcome. Dr. Rasin, sorry, I think there's some problem in your mic and we are unable to listen to you. Okay, let's go ahead. Thank you, Dr. Husni. You are back. Let's start and do give me feedback if my voice is getting low, okay?
Okay, sure.
Because when I am presenting the case, you people are giving me feedback. I'm so thankful to all of you in the Zoom chat box. The thing is that when the presentation is open, I am not seeing the Zoom. I am not seeing the Zoom chat box. It is very important that one mic should be unmuted. Okay. Let's go ahead. So we are at the P's. Incorporate in your neurons. First P, periods. Second P, pregnancy at present. Third P, previous pregnancies, complications there, conditions there. Fourth P, pills or OCPs. Now we are heading towards the end. but still we are left with systemic inquiry. But officially, unofficially, you can say that this is the end of history taking in a structured way. So history taking about the social. This is the social questions. So, you can say socio-economic history taking. Okay, so remember the mnemonic which I am always teaching you people in the course is Sajid loves tea. So Sajid is a name, a male name. You people know it very well. Loves tea. He loves tea. So in the Sajid, we are completing it, and loves only L and tea only T. So let's start. Let's go. Do you smoke? As for smoking, do you smoke or any previous history of smoking? A very common mistake in our PACES candidates. So do you smoke? No, I don't smoke. I don't think so. This is cancer. He was smoking whole life. He just stopped it about a year back. If he's saying, yes, I am smoking or I am having previous history of smoking, it is must for you to ask how many sticks per day and for how long. Why important? Patient is smoker, this is cancer. Patient is smoker, this is COPD. No. Quantify it. If the patient is smoking, say for example, 10 sticks per day for 1 year, do you think that it is enough to cause cancer or COPD? I don't believe. Similarly, if the patient is smoking 30 sticks per day for last 30 years, now I am getting more confident towards cancer or COPD. So few things over there, very important. And you should ask the patient, number one, do you smoke? If no, any previous history of smoking. Number three, how many sticks per day? Number four, for how long? And if he's saying, yes, I do smoke, so you will say that, sir, smoking is injurious to health, and I advise you to quit it. And in this regard, I am referring you to smoking cessation programs. Then the second question, do you take alcohol or any previous history of alcohol intake? Again, the same fashion. Previous history, previous history, previous history. Because I am thinking multiple things linked to alcohol. My patient is having cardiomyopathy. Right now, not taking any alcohol. Stopped just 1 year back. Any previous history of alcohol. My patient is having CLD. I'm asking any history of alcohol. Are you taking any alcohol? He's saying no. But when I'm exploring, patient was taking alcohol for 30 years. So right now, are you taking alcohol? Number two, any previous history of alcohol intake in the past? If yes, how many units per week and for how long? And I'm teaching my candidates always that lot of time, rather majority of time, the patient is not telling you the units. He's telling you, I am using white wine, say, for example, 3 glasses. I'm taking red wine, say, for example. I'm taking sprit, 3 small glasses per week. So you should be asking about, very importantly, which type of alcohol. And if you're saying white wine, and I have shared, I think, the chart, even your journal paces military group, that which alcohol contain how much amount of units. This is very important. Please memorize it. Then S for smoking, A for alcohol, J for job. And in the job, what is your job and what do you do for living? Because multiple conditions are linked with job. Policeman coming with myalgia peristaltica. SOB, ILD, sandblasting. Cancer, nicotine factory. So ask about the job or what do you do for living. Also, it is important, you want to quit the job of the patient because he is having, say, for example, occupational asthma. Say, for example, patient is having dust allergy and he's working in sandblasting. Say, for example, patient is a cab driver and he's bumping into objects because of tumor in the pituitary gland compressing an optic chiasma. The job is very important. How is your financial support if jobless? Who is taking care of your finances? If no one, I will be talking to our occupational health, I will be talking to our social health teams and see how we can help you in this regard. So, Sajid, job. I for illicit drugs. Do you take any illicit or party drug? Why I am mentioning two words? Reason is that multiple patients taking illicit drugs, they don't think that this is a party drug. Or multiple patients taking party drug, they don't think it as illicit drugs. So try to ask both things. Do you take any illicit or party drug? If yes, then through which route? Sniffing method or injecting method? If IV route, then are you sharing the needles? A common mistake in our courses. Patient is taking cocaine. Patient is injecting cocaine, and candidate is making it as HIV, as hepatitis B or C. But the patient is not sharing the needles. So if there is IV route, I request you humbly, please focus on this point. If IV route, are you sharing the needles or not? Very important. Then, do you drive? Of course, it has implication. And if you are thinking that the patient need to restrict the driving, you should say that you should inform the DVLA because it is quite risky, not only for you, but also for others. How these symptoms are affecting or impacting your life. So, love. Sajid loves tea. L for life, life, life. Explore the impact on job, family life, hobbies. We will not go in the detail of it. We will simply ask how these symptoms are impacting your life. This question is more of to show the empathy to the patient that I am empathizing that your condition is really need medical attention or help. Last but not least, any recent history of travel before the onset of these symptoms and explore it very carefully. History taking of the travel is sometimes very pertinent. And if you are not exploring travel history properly, you can miss the diagnosis of malaria, meningitis encephalitis, hepatitis, TB, endemic diseases like tropical sprue, others. So make it a habit to ask following questions in the travel history, and I am going gently and slowly so that you people should absorb it. Number one, any recent history. What I mean by recent? Recent means before the onset of these symptoms. So, do you have any recent history of travel? Yes, I'm having recent history of travel, and you are thinking that the symptoms are because of travel history. So, patient is having, say, for example, loose motion about 3 months back, and he traveled 1 month back. So, this is not a temporal relationship with the symptoms. Patient is having, say, for example, travel about 7 days back, and the fever onset is about 15 days back. So it is not having any temporal relationship, and this is a pitfall, and you will catch a wrong diagnosis. So let's go ahead towards our travel history. First thing, to establish the temporal relationship with the travel. That is, sir, do you have any travel history before the onset of these symptoms? Yes. Number two question, exactly where he is traveling. India, Pakistan, these countries. I am thinking about TB, malaria, dengue. Patient is traveling towards Malaysia, Indonesia. I'm thinking about tropical diseases, tropical sprue, say, for example. Patient is traveling towards Africa, HIV, say, for example, malaria. Patient is traveling towards, say, for example, like any travel, all the areas have their own implications. Okay, so we should be exploring in a non-judgmental way. We should respect, and we are respecting each and every country, and we should be extremely polite, non-judgmental. And every disease, every country has its own disease patterns. Now, second question, where you are traveling. Number three, which sort of tour was that? Imagine I am going to appear to you, I am going in the UK to appear in the PACES exam. Chances are very less that I will be doing the leisure activities there. Say, for example, I am going on a business tour to India. I will be having very free time to travel and roam around and, visit the places there. So there's a difference. So which sort of tour is that? Then fourth question will be where you were staying. I am going to Bangladesh, I'm going to India, I was staying in hotel 5 star. I am going to UK and I am, say for example, staying on the street. So it is different. Scenario is different. I'm going to Pakistan, I am staying on the street. The scenario is different. So which sort of hotel? How was residence? Fifth question, were you taking any bottled water or tap water? Multiple conditions, giardia, dysenteries, and all hepatitis which are spreading through fecal route. I'm just giving you examples. I'm not going the causes of each and every condition because it is not a scope of this lecture. A and E can be there. Then another important question, any contact with the sick person there. I am going to Pakistan, I'm meeting a person who was coughing there. TB contact. So it is important. Then exactly what were my activities there? In the activities, again, if you have not asked before, sorry, I am asking about any casual, relationship also there and the casual encounters, non-judgmental way. And also other activities like I am visiting, say for example, forest there, tick bites, mosquito bites, malaria, dengue, tick bites. I am visiting caves, lakes, giardia there. So travel history must be explored in this fashion. Last but not least, are you completing all your preventions and prophylaxis or not? Like malaria, for example. So what are the questions? Number one, establish the temporal relationship of the travel with the onset of symptoms. Number two, where you were traveling. Number three, exactly which sort of tour was that. Number four, what were the activities there? Number five, where you were staying. Bottled water or tap water, hotel, 5 star hotel food or street food. I love street food of Bangladesh. I love street food of India. I love street food of Pakistan. I'm enjoying there. I really love street food. I'm telling you my personal choice. But the thing is that I'm getting dysentery, say for example. Say for example, I am going to Japan and I'm taking half-cooked meals, half-cooked sushi, or say for example, half-cooked rice. So own implications. Then visiting to lakes, caves, forest. And last but not least, are you completing your prophylaxis like malaria and others or not? Dr. Hosni, my voice is clear?
Yes, Doctor.
Amazing. Okay, so up till now, this was a structured history. And we should try our level best to complete it as much as we can. And take my words, if you're well practiced, you can easily complete it in maximum 8 minutes. Take my words. You are practiced, you are mature candidate, you are presenting and you are practicing. It will take maximum 8 minutes. And this was the similar history taking skeleton as we have discussed in our last station to the previous paces pattern, with slight modifications in this new presentation and new techniques and new methodologies. Now, the systemic inquiry, we are cutting it short in our newer PACES 23 pattern. We don't have extra time to dig it out. Let me first repeat very fastly what we have discussed up till now. So we started from there, that is introduction, then presenting complaint, either Socrate if pain or Ordipara if no pain, then specific history of each symptom, like hematemesis has its own history, diarrhea has its own history, SOB has its own history, eye problem has its own history, we're exploring. Then a differential diagnosis, That is the causes. What are the causes of hematemesis? What are the causes of chronic SOB? What are the causes of chronic cough? What are the causes of pedal edema? We are exploring it. And also I'm considering if I am writing any differentials from outside to rule them out right now. Then I am taking the questions from the relevant system. If I am having cough, I am very interested to ask all pulmonology questions. If I am having, say, for example, fits, I am exploring all questions of CNS. Then ultimately, next is the bullets, missiles in your pocket. That is the journal question, and we should ask each and every question from these questions. Then past histories, allergies, medication history, family history, sexual history plus minus depending upon my case, gynecological and obstetrician history if the patient is female, and socio-economic history. This is our skeleton, and we have to inshallah follow it. Now we are starting systemic inquiry, and my suggestion is that you will give only 30 seconds or 45 seconds or maximum 1 minute to this portion. Systemic inquiry is always for the candidate to be sure that I am not having this diagnosis or I am not missing any important thing. Systemic inquiry in PACES 23, time is very less, so we will be deciding very wisely. Once we have completed our history up till now, we will stop over there. I will have a break of 5-10 seconds. I will plan myself what I should ask in systemic inquiry and what I should omit in systemic inquiry. So what I am writing right now in my screen, or it has been in front of your eyes, it is not a must for you to ask all the questions. This is now on your discretion. I am writing down almost all the symptoms of each specialty. So it's up to you which question you think they are linked to your scenario and which questions are totally not important. So let's discuss altered bowel habits, cover nausea, loose motion and constipation both, feeling sickness, nausea or throwing up, vomiting, abdominal pain, abdominal distension like ascites, blood in vomiting or from back passage, yellow discoloration, that is jaundice. In nephrology, any change in the amount of waterworks, any change in the frequency of waterworks, any blood or foam in the waterworks, any burning or pain in the waterworks, any passage of stone ever in the waterworks. Ever mean that you are also covering previous history of passage of stone. So it's up to you whether you want to skip nephrology, whole nephrology, or you want to ask one or two questions. There's some noise in some mic. Please try to keep it mute, or please avoid the mic if you can, Dr. Husni.
Oh yes, Doctor. She's my daughter. Okay. Now she's calm. Thank you. Sorry. Yeah.
Okay, welcome. No problem, Dr. Husni. No issue. Really no issue. So it is on the discretion of our candidate whether he or she wants to ask and how much he wants to ask. Then pulmonology. I am choosing these questions very wisely. If you're asking them, your whole system will cover. So in the pulmonology, any cough, if yes, productive or non-productive, any coughing up of blood, hemoptysis, any difficulty in breathing, any noisy breathing, that is wheezing, any chest tightness or chest pain. In the cardiology, again, chest pain, racing and pacing of heart, that is palpitations, any SOB specifically or lying flat. And if the patient is saying that I am having SOB on lying flat, I will suggest that better question is to ask, if yes, then do you gasp for the air when you lie down in the bed? This question is also nice and fine if you ask what number of pillows he is taking or using, but please interpret it carefully. Some people have the habit to use 2 pillows. It's their habit. It is their habit. So if he's saying I'm using extra pillow, interpret it very cautiously then. Then any foot swelling, it will be bilateral. Any excessive fatigue or tiredness, heart failure. So we are again covering all important symptoms of cardiology. You will choose what you need to ask pertinent to the information which was provided to you by the patient up till social history. Endocrinology, any bone pain or frequent fractures, your friend Paget disease, other condition of the bone, any weather preferences or problem in adjusting to extreme of temperatures. I am writing down both questions. Why? Because sometimes the patient is confused. What do you mean by weather preferences? He is saying no to avoid the question. So any weather preferences, or you can ask any problem in adjusting to the extreme of temperature. Any shakiness, that is tremor, any change in the appearance of heart, feet, and hand size, your friend acromegaly and others, Paget, then any numbness, tingling, or spasm in the hands and feet. This is showing us that there is hypoparathyroidism leading to hypocalcemia. And you know very well, hypocalcemia is a common scenario coming sometime after surgery of thyroid, coming sometime in autoimmune polyglandular syndrome type 1. Any dizziness, it is showing us Addison disease, specifically standing from sitting posture. Any darkness or pigmentation of skin, it will cover your friend acanthosis nigricans. It will also cover the pigmentations of Addison disease. In the neurology, I am asking any decrease in the power of any limb, any numbness, burning, or tingling sensation anywhere. Anywhere means that he is even now bound to tell me if there is any numbness or burning on the face. Day before yesterday, I think we were doing in our course a case of CP angle tumor. So I was giving to candidate the case of CP angle tumor with fifth nerve palsy, sixth nerve palsy, seventh nerve palsy, eighth nerve palsy. And this question, if is asking like that, any numbness, burning, or tingling anywhere, it is also covering face, and I am bound to give that history that yes, I am having numbness on the face. Any balance problem, your friend cerebellum, any uncontrolled or abnormal movements, any history of headache or fits. Again, you are asking meningitis, encephalitis, bleedings, SOL, multiple things. Any vision problem. Three things are really important to ask in vision problem if your case is linked with neurology or if you want to rule out neurology. That is double vision. Again, two etiologies. Either the problem is in the extraocular muscle or the nerve supplying that extraocular muscle is having palsy. Like, you know, the nerves, abducent nerve and oculomotor nerve and trochlear nerve. I'm not giving the details, but just I'm giving you a clue. Blurring of vision can be because of papilloedema, bumping into sideways, that is pituitary tumor compressing an optic chiasma. Any decrease in hearing or ringing sensation, vestibulocochlear nerve problem, multiple problems which are linked even with sometimes facial nerve palsy like your CP angle tumor. So it is very important to ask this question also. Any difficulty in letting food down, your friend myasthenia, your friend motor neuron disease, your friend stroke, they all can link with dysphagia. So if you are thinking that this patient can have neurological problem or your case is actually neurological case, you must ask this question. So this is like you finish your history over there on the socioeconomic history. Now these questions, these questions, these questions, these questions, these questions, these questions, they all are on your discretion. And we will not waste time in doing a long systemic inquiry because ultimately maximum at the 9 minutes we should start our examination. So I have tried my level best to summarize the history for you, teach you how to take a medical history, Be confident in your differentials. And if you are taking the history in this passion, inshallah, hopefully, you will come up with your 3 good differentials. And you will be very confident that I have ruled out other associated differentials or symptoms. So I am giving total 5 minutes almost to the question answer session. If anybody is having any confusions, any problems, any issues, any difficulties, any confusions, you can ask me. You can use the raise hand option to come forward. If anybody wants to ask any question, you can use the raise hand option given there in our Zoom software, and I will be unmuting you. Take my word, this history is really not difficult. It just need practice. And if you're practicing well, once these questions are on your tongue, inshallah, very soon the the ties of your tongue will open, and you can easily remember them whenever you're taking the history, not only in your exam, but also in your real life. Dr. Rasin, your mic has been unmuted from my side. Please go ahead.
Hello, Dr. Salman. Can you hear
Oh,
me now?
yes, I'm listening to you. Yes, very beautiful. How are you, Dr. Rasim?
I'm really happy to hear the voice of my old friend again.
Thank you, thank you. Go ahead, Dr. Rasim.
Okay, Dr. Salman, you see, you used to tell us a trick before now that in BCC you are allowed to bring up the past medical history and drug history early in the consultation. Okay,
You're right.
So in this type of consultation, this a little bit lengthy, can we still do this practice or not? Because it's really helpful.
Dr. Rasin, you can do, okay? And even you can do the examination first. But I just worry about one thing. Sometimes the candidates are, say, for example, you are suspecting that your condition is likely linked with some drug abuse. Okay.
Yeah.
Say, for example, this condition is linked with IV drugs, say, for example. You can ask even in the start, but better is that you should ask when the time will come. Why? Because sometimes the candidate are asking earlier, then they are totally out of the scheme. They are wandering here and there at where I was and what I'm skipping. So if you are confident, you can easily ask, no issue.
Okay. Thank you, doctor.
Welcome. Dr. Iman, please unmute.
Hello, doctor. Just I miss the questions about past history and allergy.
Okay, so in the past history, we are usually asking following questions. Number 1, have you been diagnosed by any condition in the past? Number 2, how well the control is? Number 3, are you in a regular follow-up of those conditions with the doctors? Number 4, any complications if he is encountering of those conditions. Say, for example, in diabetes, I'm giving one example. I am bothered about vision problems, stroke, chest pain, peripheral arterial disease, peripheral neuropathy, CKD. So I should be ruling out with just one question. It will maximum take your 20 seconds or 15-20 seconds. Then of course, I am also asking about the medication which the patient is taking for this condition, and in the past history of surgical procedures, medical procedures, dental procedures, as well as tattooing, hospitalization. They are very important. If the patient is having hospitalization, I am bothered about why he was admitted and which medications were given. Say, for example, my patient was admitted with the loose motions and he was treated. Right now, he's having reactive arthritis. So I can say that it might be linked with that etiology. Say, for example, patient was having some chest infection, some abscess treatment. He was giving, antibiotics, and right now having and the complication of those antibiotics or associations like pseudomonas colitis. So it is also a clue. Okay. In the allergies, I am asking about food allergies, medication allergies, pollen dust allergies, at least these much should be asked specifically in dermatological cases and pulmonological cases. Clear?
Okay. Yeah, clear.
Welcome.
Okay.
Dr.
Thank
Abeda,
you.
please unmute.
I want to ask if this format of yours is pretty good. Will it work for PLAB 2 exam as well?
Dr. Abda, I am having no clue about the PLAB 2 exam, and I should look into it and then I can get back to you, because I am
All
not
right.
having any idea like what is the difficulty level and maturity level of PLAB 2. But yes, this format will be very good for any exit exam of internal medicine.
All right. Thank you so much.
Welcome. With this, we are concluding our session. I am really thankful to all of you for listening to me and be attentive, and you have cooperated with me during the session and by to conduct it smoothly. And special thanks to all of them whose mics were unmuted. Have a good night and goodbye.